Welcome to This Week in Obstetrics and Gynecology. This week we're covering 10 notable papers spanning cervical cerclage and labor induction on the obstetric side, recurrent pregnancy loss and fertility treatment on the reproductive side, and gynecologic disease phenotyping, cancer disparities, and new practice policy. Let's dive in. We start with the cervix, where two papers land in the same week from different directions. Obstetrics and Gynecology has published a new American College of Obstetricians and Gynecologists clinical practice guideline on obstetric cerclage, developed with an a priori protocol, a comprehensive librarian-led literature search, and a modified grade evidence-to-decision framework, covering indications for cerclage across cervical insufficiency, prior obstetric history and cervical shortening, along with surgical approach, perioperative management and alternative therapies, with each recommendation graded for strength and evidence quality. Sitting alongside it in BJOG is a secondary analysis of the C-stitch trial that asks a question the guideline can only partly answer, which is how high to place the stitch. Among just under 2,000 women with cerclage height recorded, about a quarter had a high cerclage with bladder dissection, and 3/4 had a low cerclage without it. Pregnancy loss, the primary outcome combining miscarriage and perinatal mortality, was similar between the two techniques, at roughly 6 to 7% in each group. So there is no signal that the more extensive dissection saves babies. What did differ was gestational age. High cerclage was associated with a mean prolongation of about half a week and roughly a 40% lower rate of birth before 32 weeks. That is an observational comparison within a randomized trial, with technique chosen by clinician preference, so confounding by indication is entirely possible. It is not grounds for changing your default approach, but it is a reasonable prompt to look at your own practice, and it is the sort of question that deserves a dedicated randomized trial. Staying in the delivery suite, BJOG also publishes a systematic review and meta-analysis of vaginal misoprostol versus vaginal dinoprostone for induction of labor at term, pooling 44 trials with roughly 7,000 women in each arm. Misoprostol increased the odds of vaginal birth within 24 hours by about half, cut oxytocin augmentation by roughly a half, and shortened the induction to birth interval by nearly 4 hours, with heterogeneity acknowledged as high for the primary outcome. Caesarean rates and adverse maternal and neonatal outcomes were comparable. The clinically useful detail is in the subgroup analysis. At the 25 microgram dose, efficacy was preserved while uterine hyperstimulation with fetal heart rate changes was lower than at 50 micrograms or more. For units still defaulting to dinoprostone, this is a solid basis for a shared decision-making conversation about a cheaper, more effective agent, provided you commit to the lower dose. Our second theme is recurrent pregnancy loss, and here the news is largely deflationary. In human reproduction, Odendahl and colleagues report the first placebo-controlled randomized trial of preconceptual doxycycline for chronic endometritis in women with recurrent miscarriage. Across 27 United Kingdom sites, more than 2,000 women were screened by luteal phase endometrial biopsy with immunohistochemistry for CD138, and 438 who screened positive were randomized to doxycycline 100 mg twice daily for 14 days or identical placebo. Cumulative live birth or ongoing pregnancy was essentially identical, about half of women in each arm, and the trial was stopped at interim analysis under its adaptive Bayesian design. Just as important is the mechanistic finding. In more than 200 paired biopsies, CD138 staining varied to the same degree after placebo as after doxycycline, which suggests that much of what has been read as treatment response in earlier uncontrolled work is simply intercycle variation in the marker itself. If your unit is testing and treating for CD138 defined chronic endometritis, this trial argues for stopping. Set against that negative result, Fertility and Sterility publishes a Danish nationwide cohort of more than 360,000 women, showing that endocrine disease, present in about 15% of the cohort, was associated with pregnancy loss in a graded way, with the association strongest in women with 3 or more losses, where the odds were increased by roughly 80%. All the major endocrine diagnoses contributed, including thyroid disease, polycystic ovary syndrome, and diabetes. Two nuances matter. The association was actually stronger in women whose endocrine diagnosis came after the index pregnancy, which points to undiagnosed disease at the time of loss rather than to treated disease causing it. And endocrine disease in a parent or sister was modestly associated with pregnancy loss, independent of the woman's own diagnosis, hinting at shared genetic or environmental factors. This is registry data and cannot prove that screening helps, but it supports a low threshold for targeted endocrine evaluation in recurrent loss. The fertility theme continues in ultrasound in obstetrics and gynecology, where Martins and Nastri pool 17 randomized trials and more than 10,000 participants comparing endometrial preparation with ovulation, meaning natural, modified natural, or stimulated cycles that retain a corpus luteum against artificial programmed cycles for frozen embryo transfer. With high certainty evidence, preserving ovulation cut pregnancy loss by about a quarter, with clinical pregnancy rates equivalent. Live birth was comparable overall on moderate certainty evidence, but when trials at high risk of bias and one outlier with a large imbalance in cycle cancellation were excluded, live birth favored ovulatory preparation by roughly 15% relative. There was also a non-significant trend towards fewer hypertensive disorders of pregnancy with ovulation, and no difference in macrosomia. The practical message is to default to a preparation that maintains a corpus luteum while managing your protocol to keep cancellation rates low, because the live birth advantage depends on not losing cycles. Turning to gynecology, the American Journal of Obstetrics and Gynecology carries 2 papers about heterogeneity, one biological and one structural. Sasamoto and colleagues pooled 3 population-based studies from North America and Europe, comparing roughly 1,200 surgically diagnosed endometriosis cases against a similar number of controls, and stratified by lesion macrophenotype. Superficial peritoneal disease alone accounted for about 70% of cases, with endometriomas, deep lesions, and mixed phenotypes making up the remainder. Early menarche, at 11 years or younger, was associated with superficial disease and with combined deep plus endometrioma disease, but not with endometrioma or deep lesions alone. Chronic overlapping pain conditions were associated with superficial and deep disease but not with any phenotype including an endometrioma, and unsupervised clustering reproduced these distinct patterns. This is cross-sectional and subject to surgical ascertainment bias, but it argues that lumping all endometriosis together in research and possibly in counseling obscures genuinely different diseases. Meanwhile, Desjardins and colleagues analyzed nearly 1.4 million gynecologic cancer diagnoses in the United States Cancer Statistics Database from 2001 to 2019. Late-stage diagnosis was markedly more likely among non-Hispanic Black, Hispanic and Asian or Pacific Islander women than among non-Hispanic white women, with adjusted odds roughly tripled or worse depending on cancer type. High social vulnerability at county level, and living in a county with no gynecologic oncologist within 100 miles each, roughly tripled and roughly doubled to triple the odds of late-stage disease respectively, and race and vulnerability interacted for endometrial and cervical cancer. Over the study period, late-stage cervical cancer declined while late-stage endometrial cancer and uterine sarcoma increased. 2 policy documents round out the week, both in obstetrics and gynecology. A clinical practice update on salpingectomy for ovarian cancer prevention reaffirms complete bilateral salpingectomy at the time of obstetric and gynecologic surgery, and importantly, extends the recommendation to make salpingectomy available during non-gynecologic abdominopelvic surgery, updating the 2019 committee opinion. And a committee statement reviews the Pregnant Workers Fairness Act, the federal law requiring covered United States employers to provide reasonable accommodations for limitations related to pregnancy, childbirth, and related conditions, including what supporting documentation is expected of clinicians. Knowing how to write that accommodation note is now part of routine obstetric care in the United States. If you only have time for one paper this week, make it the doxycycline trial in human reproduction. It is a properly powered placebo-controlled answer to a question many recurrent miscarriage clinics have been treating on faith, and it should change what you test for and what you prescribe on Monday. Here are the key takeaways from this week in obstetrics and gynecology. Preconceptual doxycycline does not improve live birth in CD138 defined chronic endometritis, and the marker itself fluctuates between cycles. Vaginal misoprostol outperforms dinoprostone for birth within 24 hours, and the 25 microgram dose gives you that benefit with less hyperstimulation. High versus low vaginal cerclage made no difference to pregnancy loss, though high placement was associated with slightly longer gestation and fewer births before 32 weeks, and should be read as hypothesis, generating alongside the new American College of Obstetricians and Gynecologists cerclage guideline. For frozen embryo transfer, favor endometrial preparation that maintains ovulation and keep cancellation rates low. Consider targeted endocrine evaluation in women with recurrent loss. and in gynecology offer opportunistic salpingectomy more broadly, including at non-gynecologic abdominopelvic surgery, while recognizing that where a patient lives and how far she is from a gynecologic oncologist still strongly predicts late-stage cancer diagnosis. That's your roundup for this week in Obstetrics and Gynecology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And think of one colleague in any specialty who never has time to keep up with the literature. Tell them about Audio Scholar, a free 10-minute weekly for every specialty to listen to in any podcast app or to read at audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.